Episode of Functional Medicine for Real World Impact. My name is Tracy Harrison, and I'm delighted to share with you today some clinical pearls and insights about how hormone imbalance can begin in the gut. So often we approach the widespread hormone imbalance in our practices as being evidence of glandular dysfunction. Indeed, sometimes it is. But more often than many practitioners realize, the roots of hormone imbalance are actually found in our gastrointestinal tract. Many patterns of hormone imbalance might originate upstream in impaired digestion of food or absorption of nutrients or imbalances in microbial signaling from our intestinal microbiome. The reality is that the gut itself influences the production of hormones, the activation of hormones, and their clearance. So let's dive into how hormone imbalance often begins in the gut. Today, I'm going to be covering 5 key insights that you can apply right away in your practice. The first of these is, of course, about overall hormone nutrient demands. Of course, whether we are making insulin, whether we're making T4, thyroid hormone, or cortisol or estradiol, all biochemicals in the body, including hormones, require micronutrients for their synthesis. They usually require amino acids, for example, for the synthesis of peptide hormones. We require cholesterol and dietary fats in order to form the steroid hormone backbone that is the foundation of many different hormones in the body. And we require a variety of vitamins and minerals as cofactors. These, in particular, are needed to activate the enzymes required for the various cascade of hormone metabolism. This final one is a key consideration because it's not just hormones themselves that are having hormonal effects in the body, but also the metabolites of these hormones. And indeed, as I said earlier, the gut plays critical roles in the synthesis, the usage, and the clearance of hormones. So, first of all, we need to draw our attention to where maldigestion and malabsorption may actually be impairing our ability to get nutrients into the body that are needed for steady state, ready hormone synthesis. Many people in your practice today are wrestling with some level of maldigestion and malabsorption. We were just discussing a case yesterday of a woman that had marked pancreatic insufficiency. She had steatocrit, she had bile malabsorption. And all sorts of opportunistic overgrowths. And yet she had no GI symptoms other than episodic constipation. We need to remember that maldigestion and malabsorption can be simmering behind the scenes and impairing our ability to bring on board micronutrients for hormone synthesis. In particular, I encourage you to think about 3 categories of people in your practice. First of all, those who are using acid suppressing medications, whether it's proton pump inhibitors or H2 receptor blockers. These are creating hypochlorhydria in the stomach on purpose, very much in pursuit of acid reflux relief. But these medications are also, by definition, creating maldigestion. We need good, strong stomach acid to denature proteins, unwind the yarn ball of polypeptide chains, if you will, so that we can readily digest them. So these are individuals who generally are going to need some support with digestion. They may need supplemental hydrochloric betaine with pepsin in order to supplement stomach acidity. In milder cases, for example, sipping on water that's been diluted with an acidic liquid, such as lemon juice or apple cider vinegar, may also help to provide some maldigestion symptom relief, but also help to just enhance our ability to degrade food so that we can actually absorb our nutrients. The second category of patients in your practice who likely have maldigestion are those who have type 2 diabetes. Research shows that by the time metabolic disease progresses to the point of creating elevated blood sugar, this is where the pancreas is not keeping up with glycemic demands in the body. We're not making enough insulin. The pancreas has often become dysfunctional or less responsive to our dietary and glycemic load. Research shows that a substantial percentage of those patients, depending on the study, it's anywhere between 25 and 50% of those patients, are also going to struggle with exocrine pancreatic insufficiency. They are not making enough insulin for glycemic demand, but they also are often not making enough digestive enzymes for our digestive demands. These individuals can indeed experience recovery of digestive function as you work with them to address the roots of their metabolic disease, help the pancreas to be more appropriately responsive. And indeed, well applied functional medicine can achieve that. But in the interim, these individuals often need help with supplemental digestive enzymes taken with a meal in order to ensure that we are appropriately breaking down our foods. We're getting ample supply of all the different types of enzymes that are needed to isolate individual nutrients to allow their absorption. Thirdly, individuals who have more progressive metabolic disease, long standing type 2 diabetes, or other sources of fatty liver, in particular, non alcoholic fatty liver disease. This, unfortunately, is a downstream consequence of type 2 diabetes, where the high glycemic load has led to a lot of fatty incorporation into the liver itself, this making the liver tissue, the hepatocytes, less functional. And this often leads to trouble with bile. Bile as being the third of the three digestive substances that are critical for isolating micronutrients. And if we have hepatic biliary congestion, which is often at play when even we have subclinical levels of fatty liver, we may struggle to make optimal levels of bile or to transit that bile through the biliary tree for collection in the gallbladder. And even if we collect it within the gallbladder, we may struggle with gallbladder emptying. This is especially true when individuals have dysmotility or notably slow or fast transit time through the gut. This is common in your patients, in particular women with hypothyroidism, even subclinical hypothyroidism, where dysmotility in the gut overall may be leading to poor peristalsis and a sluggish migrating motor complex that's moving uh, chyme slurry of our food through the intestines, moving our microbial debris through the intestines. And this sluggishness can not only cause bloating and distension and sometimes invite microbial overgrowth, but we can also struggle with upper GI dysmotility and poor gallbladder emptying that impairs our ability to bring on board dietary fats and fat soluble vitamins. So, when you think about all of these patient populations, there are a lot of people who likely struggle from maldigestion. Then, of course, there are also individuals who might struggle from malabsorption. This is because we perhaps have experienced some wear and tear on the mucosa, especially in our small intestines, which is where we absorb the vast majority of our micronutrients. There's a huge array of your patients who may wrestle with this, individuals who regularly use pain relief medication, NSAIDs, especially ibuprofen, can experience mucosal degradation because of the mechanism of action of the drug. This can cause, again, oxidative wear and tear on the lining of our intestines that might impair our ability to absorb nutrients. If your patients have been wrestling with some overt dysbiosis, maybe candida overgrowth or some type of opportunistic bacterial overgrowth, maybe a parasite, when this is long-standing, it can create a lot of wear and tear on our intestinal mucosa as our immune system does battle with the microbial threat. And so, even if we have good digestion, we can end up with malabsorption, and we may need to support these patients with some mucosal nutrient support, consuming mucilaginous foods and herbs, and consuming targeted anti-inflammatories and perhaps amino acids like L-glutamine to help to heal the tissue in the intestinal lining to ensure it can work at its best for absorbing the nutrition that our digestive secretions have worked hard to isolate, to mobilize for serving biochemical needs. So that's the first category. That, but again, whether we're forming cortisol or estradiol or insulin, we need nutrients. And so, gut dysfunction in the arena of maldigestion and malabsorption might be holding back your ability to optimally synthesize nutrients. The second concept I want you to be aware of has to do with insulin and with the rising use of GLP-1 medications. This topic is certainly front and center. And of course, we need to remember that there are many different gut balances and imbalances that influence our natural release of gut hormones like GLP-1 and other incretins like GIP or GIP that play direct roles on insulin regulation and also appetite, because these gut hormones also influence gastric emptying. But if we have dysmotility, where we have sluggish or accelerated gastric emptying, again, this can be especially at play for individuals who might have hypo or hyperthyroidism. The thyroid hormones play a huge role in basal metabolic rate in cells throughout the body. And to the extent that skewed high or low thyroid hormones are making our GI motility faster or slower than optimal, we're going to be affecting a lot of other gut hormones and then the regulating actions they provide. It's also true that we need healthy bacterial populations that can be fueled by the fiber in our diet in order to create short chain fatty acids. We know that our entire GI tract, especially our intestine, is highly populated with an incredible diversity of microbes, including, in particular, a very broad spectrum of different bacteria that interact in fascinatingly rich, synergistic ways. And their diversity helps to create natural constraint and competition for food and resources and space. And we need to be feeding our microbes. Of course, they can't just survive on their own. They largely are fed, well or poorly, by debris, residue from our diet. This is where fiber is front and center to feed our microbes, especially our bacteria, so that they can produce a powerful short chain fatty acid trio. This is acetate, propionate, and butyrate. You may have heard of these, but they're all short chain fatty acids that our microbes give back to us as fuel in exchange for the fiber and some of the resistant starches and the poorly digestible polysaccharides, dietary debris that we don't readily digest and absorb. That's okay because our microbes are going to feast on it, produce a plethora of short chain fatty acids, some of which go to feed our colonocytes, the cells that line our colon. But the vast majority of which, typically 90% or more of those short chain fatty acids, are going to be absorbed through the colon lining and go throughout the body in order to regulate other immune functions, other metabolic functions, and actually brain function. It's a powerful example of the gut brain axis in action. But we want to be plentiful producers of short chain fatty acids so that we can provide good metabolic signaling. Short chain fatty acids play a key role in regulating liver function, for example, and the liver's ability to manage our glucose loads. And so it's critical that we pay attention to our diet and think about it not just about being rich with micronutrients and appropriate macronutrient profiles. Certainly, we want it to be anchored in whole foods with minimal chemicals. But we also need lots of fiber in order to support optimal motility and to feed our microbiome so they can turn around and fuel us, feed us, in particular, feed our metabolism through lots of short chain fatty acids that are going to help to regulate our metabolic hormones in order to help us to maintain good glycemic health. So that's number two. Number three takes us over to the realm of thyroid hormone as well. Yes, thyroid hormone balance can indeed begin in the gut. We know that courtesy of the HPA axis, that the hypothalamus and the pituitary are providing signaling to the thyroid gland, which is generating a lot of T4 and T3 thyroid hormone. The majority of that T4 and a significant amount of that T3 leaves the thyroid gland and then goes into systemic circulation in order to fuel our tissues. But many practitioners are unaware that, in particular, concentrated conversion of T4 to T3 thyroid hormone happens in the liver and, to a significant extent, in the gut. And so the microbiome and their metabolites, their secretions, are going to have an influence on the fitness of that thyroid hormone conversion. We also want to be able to provide plenty of nutrients that are needed for thyroid hormone synthesis and conversion. Getting back to what I mentioned earlier about the importance of not only dietary quality, but also digestion and absorption of nutrients. And T3, having plentiful T3 in the body is critical because it is by far, far, far the most metabolically active hormone. Now, certainly, cells throughout our body have the ability to convert some T4 to T3 intracellularly as well, in order to fuel its own local needs. But having sufficiency of thyroid hormone systemically does also depend on these central conversion concentrations of hormone, as I said, in particular, coming from the thyroid gland itself, but also from the liver and from the gut. So we want to take care of the gut mucosa in order to ensure optimal T4 to T3 conversion to meet systemic needs. Many women in your practice who are seeking your support for assessing and resolving chronic disease struggle with subclinical hypothyroidism, and we can't explore and can't address what we don't assess. And so measuring a good full thyroid hormone panel is essential for being able to identify where there is a subclinical, in particular, hypothyroid dynamic. And so I encourage you to consider that, and also assess gut health for every single one of your hyperthyroid or hypothyroid patients. That's the third concept and mechanism where hormone imbalance might be mediated in the gut. The fourth category has to do with the gut and sex hormones, and in particular, estrogens. We, of course, make estrogens, men and women, and the levels of these hormones can vary throughout our lives. And women in particular, our physiology is designed in order to allow for a constantly shifting level of sex hormones, in particular during the fertile years of life between menarche and menopause. For most women, this is several decades. And the body has a very finely tuned symphony of hormone synthesis and hormone metabolism to allow the levels of hormone and hormonal effects to be different every day. Certainly following your typical menstrual cycle curve, right? We know that estrogen starts off lower and then it begins to rise and peaks, and then we have ovulation and it drops, and then there's a smaller rise that happens during the luteal cycle. Sex hormones, especially during fertile years, are designed to ebb and flow with precision and synchronization. But the gut plays a critical role in this as well. Not only, as I've already mentioned a couple of times, because we need nutrients to synthesize hormones, but we also need nutrients to metabolize hormones. Many of your patients who struggle with estrogenic overload, in particular women, may have their imbalance may at its root not be an issue of ovaries gone wild and excessive synthesis of hormones, but rather downstream imbalances in hormone metabolism and clearance. Generally speaking, when we are degrading hormones, when the body wants to reduce the level of endocrine effects and cycle through hormones, it is going to metabolize them via a number of different pathways. We use phase two detoxification pathways like sulfation and glucuronidation and methylation in order to break down estrogens. And then we get estrogenic metabolites, which still have hormonal effects, by the way. But in particular, when the body is trying to control and begin to reduce steadily the effect of hormones, it's going to begin to metabolize them. And processes like sulfation and glucuronidation are nutrient dependent, right? We need micronutrients in order to carry out detoxification, right? Whether we're processing exogenous chemicals or whether we're processing endogenous biochemicals that we want to be readily able to break down and excrete. But many people, many women in your practice in particular, can struggle with impaired methylation. We often measure homocysteine as a way of assessing methylation. You can run today urinary metabolite tests, such as um, with a Dutch test, for example, where we can learn about what the body is actually excreting and what are the ratios of the different estrogen metabolites. And we can see where there might be imbalances. When the body first processes or metabolizes hormones, we tend to produce hydroxy metabolites. which, when they build up, can actually be quite pro-oxidant. And so it's important that we have optimal methylation capability so that we can methylate those hydroxy metabolites. And this requires ready, steady state supply of nutrients that our digestion and our absorption must support. Always think about assessing methylation when there's sex hormone imbalance to make sure that hormone metabolism is optimal. But there's another more insidious reason why estrogenic overload might begin in the gut. Once we have begun the metabolism of estrogens, we will begin to excrete some of those metabolites via the gut. And we carry out phase two detoxification in the liver. And then those estrogen metabolites are going to be attached to an escort that is designed to carefully and safely escort that, that sex hormone metabolite through the gut to ensure it's excreted in the stool. However, there are biochemicals that some of our microbial friends, some of our bacteria produce that can disconnect those metabolites from their escort. This is called deconjugation, where we essentially are impairing our ability to excrete these estrogen metabolites. And when this deconjugation occurs, we are much more likely to reabsorb those estrogen metabolites back into circulation where they can have hormonal effects. This is where clearance or phase three detoxification is being blocked. Certain bacteria, for example, commensal forms of E. coli, can overgrow and produce a biochemical called beta glucuronidase. It's actually an enzyme. And we need some amounts of this enzyme. It helps us to digest and make use of different phytonutrients from our plant foods, fruits and vegetables in our diet. But when we have an overgrowth of different types of bacteria, such as E. coli and some of the other bacteria that are often at play in SIBO, oh, these bacteria can produce lots of beta glucuronidase, and we end up with too much of a good thing. And this enzyme goes around severing the hand holding, severing the escort between the conjugate and the toxin, or in this case, the glucuronide and the estrogen. And in this way, a microbial overgrowth is directly interfering with hormone metabolism or hormone excretion. And until we actually resolve the dysbiosis and stop the glut of the beta glucuronidase, we're going to be more vulnerable to having an overload of estrogenic metabolites that might be causing symptoms of imbalance, often what we call symptoms of estrogenic overload or estrogen dominance. And so we want to think about, again, gut health, microbial balance, and addressing dysbiosis. A lot of comprehensive stool tests these days will actually measure beta glucuronidase. So you have a sense for whether or not we have excessive amounts of it that might be promoting estrogenic overload. But we also want to be looking at stool test profiles and understanding where there's an overgrowth that we might need to address in order to stop the blockage and help us to have better natural hormone metabolism and clearance. Now, the fifth category I want to mention today is about the gut and stress hormones. Certainly, many people in our practices struggle with imbalances and stress hormones. And today, in particular, I want to talk about excessive levels of stress hormones, in particular, too much cortisol. Lots of people in our practices, and in many ways, just a natural reflection of our sociocultural norms, are living way too often in a sympathetic nervous system state, right? Our culture tends to promote more, better, faster, do, go, fix, build, never or often not prioritizing rest and recovery and durable healing. We tend to celebrate actually people who are super stress fueled because they are achievers. They are our heroes. They can often present as martyrs or people who can put up with so much and weather so much stress. Yet behind the scenes, the body is often dramatically suffering. And certainly we are progressively courting chronic disease, including hormone imbalance. Many people in your practice, men and women alike of all ages, struggle with elevated levels of cortisol. And as a stress hormone, we know that this naturally prioritizes physiology in the body that promotes survival, right? High cortisol levels are not focused on promoting thriving, they are designed to promote survival so that we can fight and flight and freeze. As needed in order to just survive, to just get through to the next day. And this can indeed impair a lot of gut function, by the way. When we have elevated levels of cortisol, we might be living in more of a hyperadrenal state. We naturally experience poor or less frequent parasympathetic nervous system transmission. Our vagus nerve doesn't work as well. And so vagal functions don't work as well. We naturally tend to secrete lower levels of digestive secretions. We naturally tend to have gut dysmotility. And so sometimes it's actually stress that's promoting gut dysfunction that causes imbalance in the other hormones that I've been describing today. But in addition to stress itself causing gut dysfunction, we want to remember that there are many different types of stressors in our patients' lives. What I've been referring to so far is more mental, emotional, social, family, um, vocation, or career stressors, right? But we don't want to lose sight of the fact that our HPA axis, right, our stress hormone axis, can be activated and amplified also because of physiological sources of stress. We've spoken of this in prior episodes, where things such as sleep apnea or excessive exercise or inadequate sleep, all of these things might be a dramatic driver of physiological stress that even if a person feels fairly mental, emotionally stable and balanced and maybe even joyful, there are physiological drivers for the activation of excessive sympathetic neurotransmission and often a more of a hyperadrenal state. And sometimes the sources of these physiological stressors are in the gut. In particular, your patients who are struggling with dysbiosis, those who have long standing IBS. You may have been working with them for quite some time and you've seen multiple different cycles of dysbiosis, various bacterial overgrowths, or maybe there was a bacterial overgrowth and then there was a fungal overgrowth. And then maybe they went on a trip and they picked up a parasite, right? We often refer to this as the revolving door of dysbiosis, where a patient who is living in such a way that their gut terrain invites or well supports a dysbiosis. Even if you run a stool test, find a dysbiosis, and try to treat it by killing off the threat, the imbalance, the terrain often tends to invite a recurrence. And in particular, people with longstanding IBS may have wrestled with multiple different cycles of dysbiosis. Being treated, being better for a little while, maybe a few months, and then it's back. Maybe the same flavor, maybe a different flavor. But we have to remember that a dysbiosis is an infection and it is a source of stress or threat to our bodies. In particular, when the immune system is hyperactivated in the face of a microbial overgrowth that it can't quite seem to fully corral and eradicate, This can cause marked stress on our bodies. I encourage you to think about your patients with long-standing IBS and how this might be a dramatic source of physiological stress that is elevating their stress hormones. This might be contributing to hypertension, to poor sleep, and to a higher glycemic load. Often, stress hormones are the major driver of high blood sugar in people with seemingly ideal diets. Individuals who are already eating a whole natural foods diet that doesn't seem to have a strong glycemic load, we need to remember that stress hormones, all on their own, are ultimately catabolic in nature and also drive marked increases in blood sugar on purpose. Because if you need to fight, flight, and hide, you want to have plenty of blood sugar in order to do that, in order to survive. But sometimes the stressors are in the gut themselves, and dysbiosis can be a major category. The other one I encourage you to think about as a source of ongoing stress in the gut is when we lose barrier function in the gut. This is the scenario we often refer to as enhanced intestinal permeability. We know that the gut lining naturally is indeed semi permeable, a bit like a colander, where it's a bowl but that has holes in it, but the holes, of course, are of well controlled size so that the pasta doesn't leak through the holes, but the water does. Similarly, in your gut, we want nutrients to be able to move from the intestines into systemic circulation, and we want to be able to get waste products out of the body and into back into the GI tract for excretion. But we don't want there to be excessive permeability in the gut where microbial debris or inflammatory mediators, right? Cytokines, prostaglandins, right? The ammunition, if you will, of our immune system. We don't want all of this debris of the immune system's warfare in the gut to actually make it into systemic circulation. What the immune system well tolerates and corrals in the gut, when it reaches systemic circulation, can dramatically and aggressively activate our stress hormones and quite a bit of systemic pro inflammatory stress and damage over time. We can have issues with loss of gut barrier function and this enhanced permeability, where we lose the tight junctions uh, in the lining of the gut, and we end up with enhanced permeability that allows this gut debris to enter systemic circulation for a rich variety of reasons. Unfortunately, elevated stress hormones naturally promote enhanced intestinal permeability. It's normal physiology. I mentioned earlier various medications that can contribute to loss of barrier function in the gut. And that does include things over time like nonsteroidal anti inflammatory drugs like ibuprofen, uh, oral hormonal medications like birth control pills or oral estrogen replacement therapies, oral steroids, and often antibiotics, especially when they're taken for longer courses or repeated courses. These can all end up causing mucosal degradation in the intestinal lining and contribute over time to this loss of barrier function and this enhanced intestinal permeability. So, we want to be thinking about where the puzzle pieces in a unique patient case may indicate that progressive loss of barrier function is indeed likely. There's all sorts of testing available now where we can actually look and see where in the blood we may have, for example, developed antibodies against gut barrier proteins, especially tight junction proteins. Antibodies, for example, against occludin or zonulin. These can be cues that we may have lost some elevated degree of barrier function and are experiencing higher systemic inflammation as a result. So, this is where the gut and gut imbalances can definitely be signaling alarm to the systemic body and elevating our stress hormones and causing downstream dysfunction. Those are 5 key principles I encourage you to think about. How gut maldigestion and malabsorption might be impairing hormone synthesis or hormone metabolism, where gut dysmotility or a poorly fueled microbiome might be impairing insulin function, where nutrient maldigestion or mucosal degradation might be impairing T4 to T3 thyroid hormone, where T3 is by far the most important metabolic hormone in the body for influencing our overall metabolic rate. How the gut can influence our estrogenic load, especially as it relates to potentially interfering with estrogen metabolism, both via impaired methylation for making estrogen metabolites safer and less pro-oxidant in nature, and also ensuring that microbial imbalance isn't interfering with estrogen metabolite clearance by deconjugating those metabolite escorts in the intestines. And then, lastly, where gut imbalance itself, both dysbiosis and the stress of loss of barrier function in the gut, might be a major physiological stressor in creating a hyperadrenal state in our patients and clients that is causing systemic imbalance and debilitating symptoms. So, hormone health depends on nutrient availability. It depends on microbial balance. It also depends on proper clearance. And the gut is central to all of these processes. In your clinical work in the days ahead, right after you explore and focus on which hormones might be off, I encourage you to ask right away, how might the gut be central in driving this particular functional pattern? Thank you so much for joining me. I look forward to seeing you next time.